Yes, we are going to get started. Tonight's program, just so you know, this is an MS Views Now program. This program began when COVID began. All right, we put this program together so that way we're giving you COVID updates. And we're also doing it in conjunction with like another topic each time. And today's topic, what do we have? We have protecting yourself against infections. And so Dr. Hunter will be speaking about that, all right? But next, for you to know, me. All right. So for those that don't know, and I doubt that there's anyone on here that doesn't know tonight, but in case you don't, my name is Stuart Schlossman, and I am an MS patient, and I am president and founder of MS Views and News. And tonight we have our sponsors, our supporters of tonight's program. You can see our GENENTECH, BIOGEN, and BRISTOL-MYERS SQUIBB, and we do thank them greatly for supporting this MS Views Now series. Now, like I said, we have Dr. Hunter speaking tonight, all right? And again, it's about protecting yourself against infections, COVID, and other things. Dr. Hunter's going to be speaking for somewhere between 50 minutes and 1 hour. I told him he's not allowed to go more than an hour, all right? Dr. Hunter, I can't say enough about you other than thank you for being here tonight, and good luck.
Let's talk about infections in MS. And MS is basically like an infection to begin with. In fact, it's an immune disorder that's against brain cells. In keeping with the theme of infections, it's very likely provoked by what's called Epstein-Barr virus. There's a lot of reasons to think that it's a very ancient virus. It's a parasite of people normally. And 100%, every last patient with MS has this virus, which is 90% of normal people, but 100% of MS patients. And it's actually been proven that this virus, which is in the herpes virus family, we call it a herpes virus in medicine. It's not like herpes that you think about. Was proven actually in a study in the U.S. Army to always be there when people came down with MS, because the Army has a lot of blood on people, and they were able to show this. We cannot cure this virus. This virus is a permanent infection, as far as we can tell. There are studies working on it. Immunizations have been tried to make for it that haven't prevented the infection. It's a very crafty virus. It knows how to hide in immune cells, and it makes copies of itself that hide for a while, and then it comes out. It makes some cells its immortal zombies to produce it, and it provokes a lot of inflammation. And because things can cross-react in the body, it's believed it produces cross-reaction in the nervous system. The severe initial infection with Epstein-Barr is called mononucleosis, or mono. Most people with MS don't get mono. Most people with mono don't get MS, but mono is a severe version of the infection, and those are markers for people who are for MS. So someone who has mononucleosis is about 50 times as likely as someone who doesn't in getting MS. So in general, patients with MS have more serious childhood infections, and this is a virus you get from your family or friends. All right. Can we go back to the other, can I show something on that last slide, please? So if you look over here on the right side, the bottom is just a figure. It's a big virus. It's one of the bigger ones. Viruses have genes inside them that are the instructions they use to take over and make copies of themselves. And that's just an example of the genes. And the genes are very efficient and packaged. They actually work in both directions oftentimes to make them. So viruses are the epitome of really carefully stripped down. We don't always understand what all the genes do, but they've acquired these eons ago and have been infecting humans for eons. And then the outside has a membrane just like cells do in many cases, and that has proteins with functions. Let's go on to the next slide. All right, so infection and MS. You have infections when you have MS, just like everybody else. And the genes that you have were designed to deal with infections. In fact, what's different about people now than 100, 200, 300 years ago is we have many fewer infections than we used to have. In fact, we used to be infested with parasites and constant serious infections. People lived to be 30 years old if they were lucky. Now, just by sewers and immunizations, we have very few encounters with infection. Our immune system spends a lot of time in idle state, unless you have an immune disease, in which case it's always doing something. It's been looked at very carefully how genetic MS is, and actually MS is not a genetic disease, but hundreds of genes weakly predisposed to MS, and these genes nearly all have to do with fighting infection and handling vitamin D. They are very common genes. They're common because they're good genes. They help people live to adulthood. Some people, however, are more prone to serious infections than others, and as a rule, more people with MS die from pneumonia than any other cause, pneumonia being a serious infection in the chest. MS patients on average die 8 years younger, and they're 3 times as likely to die as their peers at a given age. So in general, these serious infections are bacterial ones. The most common one is community-acquired pneumonia, which is caused by Streptococcus pneumoniae. There's a vaccine for that. We'll talk about that. Sicker and ill people get something often that we don't have a vaccine for, called Klebsiella pneumoniae. And then there are foodborne infections people with MS can get too, called salmonella. You've heard of salmonella. It's associated with food poisoning. It's actually contaminated food. And you can get it in other ways, from water exposure or exposures to animals. And the pictures there on both these slides. The upper one is shingles, which we consider to be an opportunistic infection. It's from the varicella zoster or chickenpox virus. It lives in your body after chickenpox infection, and it breaks out. It lives in nerves, so it breaks out along the course of a nerve. And so these are hallmarks. These kind of infections are people with weakened immune systems. Now, they tend to be very young, very old, or immunosuppressed, like someone with cancer, immune disease, steroids, something like that. So shingles is kind of the bellwether, the canary in the coal mine that there's something wrong in the immune system. And most people who get shingles, about a third of people get shingles, and they almost all get it over the age 70. People with MS usually get it 20, 30 years earlier, and sometimes can get it more than once, which is very uncommon. So if your immune system is weak enough, you get problems with other weaker herpes viruses, like the ones that live in your mouth, called herpes simplex, and that can even go to the brain. It's very dangerous in the brain. There's an otherwise benign virus called JC virus, just to confuse things. The disease is called PML, and you've heard about this because people can get it who are on Tysabri. It's about 1% risk a year. It's about 1 in 1,000 or 10,000 on other strong medicines for MS. There are other foodborne infections. There's a bacteria called Listeria, which is famous in immunosuppressed people for making people sick who don't eat well-cooked food. And there are other pneumonias that can affect people who have very weakened immune systems, and they are less common in MS patients. All right, so just to give you an idea, when we talk about viruses, how big we are, look at this picture in the upper right side. The thing that looks like the sun is the edge of a red blood cell, which is 10 millionths of a meter, or 10 thousandths of a centimeter across. And all these other infections we're talking about are tiny compared to these. In fact, a bacteria here, an E. coli bacteria, is a tiny fraction of the size of a red blood cell. And all the viruses are smaller than that. There's a chlamydia, which is the smallest bacteria there is there, which is very small. But these other viruses, some of them are actually viruses of bacteria, are so tiny you have to have a really high-powered electron microscope and special techniques to even see them. You can't see them when they're alive. We have to see them when they're dead. And so every one of these viruses is structured more or less by this paradigm you see down in the right corner. It's got what's called a capsid, which is sometimes actually a membrane that it steals from the cell. It's got external proteins that have both structural or infectious plan, and on the inside, it's got a packaged set of genes that are either RNA or DNA in its various forms, and they are very, very tightly coiled. And it's essentially, we get the name for computer viruses from real viruses because they're essentially a hijacking of a cell's metabolic machinery by RNA or DNA to make copies of itself. Patients with MS get the same viruses as everybody else. They have this tendency towards more serious childhood affections and actually will often tell you they almost never get sick when they're older. That's amazing. It's not true when they get old, but it's true when they're adults. And viral influenza, which is probably the most serious infection that the average person gets that's a virus, is similar in MS to everyone else. Deaths from viral infections in MS are really, truly exceptionally rare. Next slide. Let's go on to the next slide. All right. This is the play card, the team roster for the immune system. And you actually share this immune system with the sharks and every other vertebrate that's descended from them. So the sharks were the first real card-carrying big vertebrate in the ocean, hundreds of millions of years ago. And everything else is descended from those kinds of fishes, what we call cartilaginous fishes, including their immune system. The immune system was already invented by them, and it works so well, it really hasn't changed. So you basically have two kinds of immune system. You have an innate immune system, which we've got in the left column, and you've got an adaptive immune system, which is extremely creative. The innate immune system is highly genetically programmed. It's triggered by microbial presence in products. And the adaptive immune system is actually genetically engineered. I'll show you this. These cells engineered by the body in many different forms to be able to recognize just about anything and learn how to deal with it. It's really quite amazing. So the innate immune system has several kinds of cells, and actually the adaptive immune system can tell the innate immune system what to do and vice versa. So the innate immune system has cells that recognize what's going on, and down at the bottom you see something called the dendritic cell. These are parked in all over your body, in the lymphoid tissues, the skin, the mucous membranes, to be able to sense what's happening and send messages and to hand off to other cells an example of what they think is going on in the environment. The other cells have some simpler functions. The phagocytes are neutrophils and macrophages. Neutrophils deal mostly with bacteria, and macrophages deal mostly with debris and viruses and other chronic kinds of infections. They basically swallow things and digest them. Then there are cells that are more like a bomber. They fly in and they dump a load of toxic material in to just try to kill everything around. There are cells that are very highly targeted. We have the ones that are called natural killer cells. They essentially are like a ninja that grabs a hold of somebody and decides whether or not they like them, and if they don't, they poke a hole in them and put them to death. And these are all cells that are genetically programmed. Now, the other cells in the immune system come in two major flavors. We call them T lymphocytes and B lymphocytes. Lymphocytes are small, stripped down cells. They have one mission. It's to make more of themselves, and basically immune memory has to do with making copies. They have some specialized forms. So the T cells in this tiny little picture up here at the top of the middle column, it shows that you have an initial T cell, but it can become many different types of cells. And the directors of the T lymphocytes are called T helper cells. They basically are scouts. First of all, they can recognize things, but they send out signals to start making cells when they're activated. They're activated when one of the dendritic cells or macrophages hands them an example of something that they recognize. This is called an immune synapse. The cells actually touch, and because the T cell has a genetically engineered signal that it recognizes on that cell, it knows that it's not supposed to be there and starts proliferating. And according to the environment, these cells will make additional signals besides telling them to multiply. They actually tell themselves to multiply. And every time immune cells divide, you have twice as many. And that's how the immune system works. Sounds like it's not real efficient, but it's efficient enough, and it's been around since the sharks, so it works well. So when the signals are to make cells, you call that a Th1 response. When the cells are to make antibodies, which is the next column over, that's called a Th2 response. When it's to go really bananas and make lots of cells, because this is really bad, it's called a Th17 response. Now, the attacks are actually not carried out by the helper cells. The helper cell's job is to go and find it and tell everybody to come, and that's what it does. The cells that actually carry out the attack are called cytotoxic T cells, or CD8s. And you see here in the middle, they sidle up to a cell. The little cell is actually a lymphocyte, but its size has nothing to do with how deadly it is. And just like with the natural killer cells, it comes up and it basically, just like you are sniffing the aroma of food, it will sniff what's inside that cell, but on specialized plates that are on the surface of the cell. And if it smells what it's looking for, it throws a bunch of grenades at it that literally just punch a hole in the cell right then, and it's dead. All right? There are also T cells that help keep the immune system under control. They're called Treg cells, and they basically send messages that mean leave that alone, or go home, turn yourself into a reserve cell. That is a very important group of cells. Now, the T cell immunity, we can't measure very well in normal medicine. We know people have T cells. If we take your immune cells out and you study them in a laboratory, you can see they respond to things, but it's much harder to study a T cell than a B cell. And that's because B cells do something very unique. They have a long-range weapon called antibodies, and antibodies are made by B cells. We'll talk a little more about antibodies, but there are different kinds of B lymphocytes. These all come down the same development system until they separate in these two different kinds of lymphocytes. And B cells also have their officers that say attack, leave it alone, go turn into a reserve. They're all little small lymphocytes. B cells are a little bigger than T cells because they have machinery to make antibodies, and that takes a little more cell than the T cell has, which just basically is a nucleus and can make a little protein, to send signals. The infantry part of B cells make what's called IgM. And when B cells are first responding and making copies of themselves, what we call blasts, they make a very sticky kind of antibody called IgM, which is designed to coagulate, eliminate, and activate a very powerful immune response. But there are also specialist B cells. These specialists are very different than these regulatory and frontline B cells. They are very long-lived cells. They are cells that last for decades, unlike the other cells in the immune system. And these cells are called plasma cells. Has nothing to do with your plasma. The antibodies end up in your plasma, but they're called plasma cells because of how they look. And they have these big, beautiful purple views when we stain them. They're very easily recognized in tissues. And they show up wherever there's a lot of inflammation. In people with MS, their brain and their meninges, the linings of the brain, are full of plasma cells because the immune system's been there a long time. Now, we're talking about fighting infection. MS is the disease pathology is a lot like the body's fighting an infection, but it's not infected as far as we can tell. There are different kinds of IgGs, are immunoglobulins. There's IgG1, which is basically means mount a really huge, nasty, immediate attack on this, and everything in the body goes for it. And there's other ones that say you need to eat this up. And there's others that call in the eosinophils to drop a bomb on this. That's what causes allergies. But that allergy response is for dropping a bomb on a parasite. That's what it's for. IgG2 and 3 and IgA are meant there to sop things up and keep things from spreading. So that's the players. I'm going to go into antibodies a little bit more because they're so important and relevant to infection. And these are different ways of thinking about antibodies. On the right side, if you look at the right side, this is how an antibody is built. It's built from dozens of different genes. There are basically 2 strands of protein. One's called heavy because it's big and one called light because it's shorter. And the antibody has a business end called the binding site that is unique to the antibody. It is set up by joining a bunch of different regions together from your genes, mixing them up just like you would take different Legos and plug them together. And in the birth of these B cells, just like with the T cells do this with a different receptor that's not antibody. You basically have a cell that's unique. And if you can imagine that a locksmith could create a set of keys that has every possible way ever possible or needed to fit into any lock possible, you just have to try them all. That's how this system works, is all the keys are already made. And what happens when there's an infection is the immune system starts looking for the one that fits. And it finds something that sticks, then it goes. That turns on full blast, and that cell starts making things. The first thing it makes, if you look over here on the left, is the IgM, which is conveniently made smaller because it's really the same size as 5 of these big ones tapped end to end. And that's what calls in the troops right away early in an infection to get things started. But most of the time, it's just one of these units. The picture up in the left is a way to think of it in terms of how the protein fills up space and what it looks like. We just draw them a different way. Now, I told you the business end is what sticks to things. Now, we do this. A lot of our medications are these antibodies. We can engineer these antibodies. We can do them a lot of ways. Nowadays, they can actually find human antibodies to do this, but we used to make mice or rats do it, and then we'd molecularly engineer the antibody to be like a human antibody, and then the body wouldn't react to the antibody. Because the antibody is like anything else. It can be recognized as foreign if it's not a human sequence. But you've got down here IgG, and IgG has 4 flavors, and you've got the IgM. IgA is what protects your mucous membranes from infection, and it soaks up those anything that's on the mucous membrane, tries to neutralize it. IgG depends on the kind of IgG is what it does. So different kinds of organisms deliver IgGs. But for example, when we engineer antibodies to do a job, like with Tysabri or Ocrevus or Lemtrada, these antibodies are done in a certain way to get a certain function. Actually, just out of trivia interest, Lemtrada was the very first engineered antibody and the very first humanized engineered antibody. Got 2 Nobel Prizes for that, and that was 40 years ago. All right, let's go to the next slide. All right, so what happens when your immune system sees something for the first time? There's a B cell response. All right. There's also a T cell response. It's harder to draw pictures of that. It's more complicated. What you get, if you look at days on the bottom, this is days after exposure. The first exposure to something, what you see is IgM appears within a few weeks. The IgM response then partially becomes an IgG response. And a simple exposure, you'll get that immunity, and it will seem to go away. It won't be visible anymore in the serum. Now, if you have a severe infection or prolonged infection or a second infection with the organism, then you get what's called a recall response. They used to call it anamnestic, but nobody can say that Greek word. So we call it a recall response. And you again get an IgM response, and you get a very dramatic and permanent IgG response. And what is that IgG response? Those are the plasma cells. They are there, they're not going away, they're always going to be there. And actually, interferon, which is our friend, in MS, it used to be the standard drug people got. Interferon is what makes the cells become IgG producing. It's the immune signal that converts them into plasma cells. It's very, very important. All right, let's go on to the next slide. All right, so how do you protect yourself in infection? Well, everybody's seen masks a lot recently. Vaccination, we're going to talk a lot about vaccines because vaccination is the best way to prevent infections with dangerous organisms. Now, there's a lot of infections we don't need to vaccinate against. You don't, normal colds and coughs, you don't usually vaccinate against because they're fairly mild. In fact, the symptoms of many viruses are the immune system going to attack them. And so even if they stop the virus replicating, you'd still feel sick because your immune system is going crazy trying to get rid of it. So the vaccination trains both your B cells and your T cells. Some vaccines are more B cell recruiters and some are more T cell recruiters, but most recruit both to a certain degree. And for some kinds of purposes, like for a tetanus shot, you really just need a B cell response. A tetanus shot is to go after a toxin so that you don't get sick from that microorganism. You can have that microorganism stuffed all through your gut, but it can't make you sick, you know. Whereas most viruses, you need T cells mainly to get rid of them, but B cells slow it down and help protect you because they make antibodies. The antibodies kind of stick to everything. It's like chaining them all up. And T cells are there, believe it or not, to kill your cells that are making the virus. Once a cell is compromised by a virus, there's no choice but to kill it. Now, cells normally start, as soon as they're infected, start making a very ancient signal called interferon. And interferon beta and alpha. Alpha interferon the immune system makes to try to get cells protected. Interferon beta, the cells make. Almost any cell can make interferon beta. And interferon beta tells all the other cells, lock the doors and close the windows. There's viruses around. And it makes it very chemically hard for the virus to infect them. All right. Now, with the vaccine, in general, the risk of injury from vaccines that are approved is very small compared to the illness we're trying to vaccinate against. It's usually about 1,000-fold difference. As far as avoiding illness, the best way for things that are communicable diseases is to avoid ill people. And social distance is fine, but it's not as good as isolation, because if it's a respiratory transmitted viruses, if you breathe the air that someone else has breathed, you will get the virus. Masks are not that effective. In general, the N95 mask is more effective than the others. The problem is wearing an N95 mask. And if you have one of these happy valves in it, they're really designed for people who are working in dusty environments. The problem is you don't protect anybody else. So the valves protect you, but not somebody else. If you are in close contact with someone who is infected for a significant amount of time, you will get a respiratory virus. They are not effective in household settings. However, other viruses that are not transmitted so much by respiratory viruses, like common cold viruses, the common cold virus is really transmitted mostly by people's hands. So hygiene really works well for that, and hand washing and sanitization, and this is also true of things that are transmitted by fecal oral transmission, which is a huge number of viruses. And you don't want to think about how that virus gets around because it started in somebody's intestine. All right, so let's talk about kiddos. Kids get a lot of shots, so do soldiers. Children are healthier than ever before because of these immunizations. We'll talk a little bit about smallpox, because smallpox in the 18th century, 60% of people got smallpox as adults, and 20% of everybody died from smallpox. That disease is gone now. It's gone because of the invention of a way to immunize people. And hundreds of years ago, in fact, and we'll tell that story. Polio is another example of an illness is gone. That virus is not gone, and there's a new virus that's like it that's not related, called the AM virus, that's occurring very rarely now, not like the old polio did. But polio can come back anytime. It's still out there in the sewers and the lakes. and people get it, but they don't get sick because the immune system knows how to prevent it from getting into the brain because everybody's been immunized. Many of the serious childhood illnesses are rare now. Pneumonia and strep infections, kids used to get them all the time. The immune system wasn't trained, they weren't as well nourished. And now from the time they're young babies, they get strep immunizations, which is what we call pneumonia vaccines usually, but they work on other kinds of strep. Meningitis, measles, which used to cause an MS-like illness, which does not occur anymore. It also caused death quite a bit. Mumps, which made people sterile or deaf, and rubella, which caused birth defects, which was otherwise a pretty benign illness. But if you got it while you were pregnant, it was a big deal. Pertussis or whooping cough and diphtheria are examples of bacterial infections where there's toxins that were very serious. Tetanus, the same. Chicken pox is a viral illness. It's now immunized against now. If you're born before 1980, you presumably had chicken pox. Virtually everyone did. But now people get immunized with what's essentially a weak form of chicken pox in order to get their immunity. Hepatitis B, and there's actually a hepatitis A vaccine now too, I lost here. And there's even a cancer vaccine for HPV. It prevents cervical and other cancers. All right, next slide. So what about vaccination? There are some things that are often said that aren't actually true. And that's the most common one I've heard is vaccines don't work. And actually, some vaccines work better than others. And no vaccine works for everyone. And the reason for this is we all have different immune systems. Up here in the right corner, there's a picture of Sir Edward Jenner, who's probably one of the most influential scientists of all time, because his work saved more lives than anybody else. Why? Because he found a practical, safe way to prevent smallpox. And they knew if you'd had smallpox, you wouldn't give it again in the 18th century. And they would actually sometimes try to give young children smallpox to prevent them from getting it when they were older. But that didn't go very well a lot of times, and they were very communicable. But what he did was he figured out that the immunity from cowpox could be transferred from person to person, and that would prevent smallpox. And that created a 19th century revolution in medicine. He was actually trained to be a surgeon by one of my cousins, John Hunter, who is the father of surgery, but he made his name as being the first physician to reduce vaccination to a practical practice. And they made fun of him back then. It may look familiar. If you look at this picture down at the right, you see a bunch of cows growing out of people because the vaccine was a cow virus. And so it was very controversial in its day, just like vaccines are controversial today. Some people say vaccines cause the disease. It's not true about the influenza vaccine, which is commonly said, but it does make the disease milder, but it often doesn't prevent it. We're still learning how to make flu vaccines. They actually have to make 3 influenza vaccines for every year and combine them together, and they're actually guessing which virus it's going to be. Sometimes that virus is the one that's going to come next year, or sometimes one of the viruses doesn't come at all. They have to start so long in advance. There are ways to make vaccines that work for all. We'll see that in the next 10 years. The polio vaccine can actually cause poliomyelitis, and it did for many decades until it was determined how you should best give it. And so they give you first an injection of the killed polio virus to give your immune system some immunity, and then they give you the oral polio virus, which is a live virus vaccine. It actually vaccinates not only the child, but everyone around them, because it's one of those wonderful viruses we call fecal-oral transmission, and I'll let you figure that out. But so we no longer have epidemics of polio. We do have some sporadic cases with a new virus that's like polio. We don't call it the same thing, even though it's basically the same thing. It's a different virus. There is a TB vaccine in Europe called BCG that can cause a TB-like illness. The chickenpox vaccine actually is giving someone a small dose of chickenpox, and sometimes they get chickenpox. It's very wimpy chickenpox compared to normal chickenpox. The old rabies shot used to cause not a disease, not a viral disease, but it caused an immune encephalitis. And this was, the old rabies vaccine was made from rabbit brains. Louis Pasteur invented this, and this eventually led to the landmark discovery that this is how you could cause an MS-like disease. But the new rabies shot doesn't do this. New rabies shot's made by biotechnology, and it doesn't do this. There is a travel vaccine called the yellow fever vaccine, which is a very important disease, vaccine historically because it obliterated almost yellow fever. But it actually can cause serious disease like yellow fever, especially in older patients and patients with impaired immunity. MS patients should never get that vaccine. But vaccines well, people are worried many times that they're going to change their DNA. They really don't. The immune system has already changed your DNA to find the vaccine response. And so the adaptive immune system is actually engineered DNA, every immune cell you have. Let's go to the next slide. How am I doing? I'm doing okay. All right, so how do you protect yourself from infection as an adult? You still need vaccines. They're not nearly as many. If you didn't have measles, mumps, and rubella over 16, you need to get it. The immunity wears off. These are bad viruses as an adult if your immunity wears off. You don't know whose immunity is going to be bad. Hep B, if you didn't get it as a child, you need 3 doses as an adult, or if you're demonstrated to be high risk and your titers are low, that's a very bad virus. Actually, more people die of hepatitis B in the past than died of AIDS. You know, it's a very serious infection for many people. Chicken pox, you need a vaccine if you don't know you got 2 doses and you were born after 1980. People born before 1980 or people who know they've had chicken pox or have a positive test don't need to get the vaccine because they've already had it. But the vaccine, in one quirk, does not make the blood test positive. So the most important thing is that you just know you got 2 doses of chickenpox vaccine because 1 isn't enough. That's been very clear. Seasonal influenza, you need every year. Someday we'll have a flu vaccine that lasts forever. But every time you get that, it helps make your flus milder the next time if it doesn't prevent it. Prevnar 13 is an amazing advance. It's a single dose, once in a lifetime in adulthood pneumonia vaccine, which gives very, very powerful lifelong immunity to pneumonia, the strep pneumonia, the bad one. And then the HPV vaccine takes several doses to protect people adequately from cancer, from this HPV virus that causes a number of different cancers. But the most common cervical cancer has gone down 90% where it's used. Over age 50, you need DPT, or what's called Tdap, which is the same tetanus shot you got as a child, but you need it to get your immunity for pertussis back. Pertussis is a very wicked respiratory illness. The Japanese call it the cough that never ends, and people break ribs coughing. It's very terrible, but it's completely preventable. And then the shingles vaccine, when people get older, the new one is 2 doses. It is not a live virus, so it's safe to get even if you're on very aggressive immune therapy. Over age 65, you get another type of pneumonia vaccine more regularly called Pneumovax 23. And if you travel a lot, you need a letter that you shouldn't get yellow fever vaccine. That people who have cancer and immune diseases can't get yellow fever vaccine. People who are older shouldn't get yellow fever vaccine. But the other things that you commonly get, like typhoid, Hep A or B, or boosters of these other vaccines, are fine. You can go online to the CDC. Actually, most of the time, CDC is pretty reliable. I don't know what's happened to them recently. Go to the next slide, please. All right, so what are the MS issues in vaccines? Now, amazingly, most of the common vaccines have been tested in MS patients. And there's actually data that vaccines may even reduce the risk of MS relapse. People have filed patents about this. The tetanus shot actually reduces MS relapses. Looks like it does. Whether it's the best way to do that, I wouldn't want to get tetanus shots regularly. But the vaccine adverse effects, like fever, joint pain, or headache can worsen your MS symptoms, or in some cases, provoke a relapse-like symptom. Even relapses, but usually it's just the fever and inflammation produce a transient problem. Now, live virus vaccines, and there are just a few of them, it should only be used when stronger immune suppressive medicines have worn off. So you don't, and there are specific warnings, and with the S1P agents like Gilenya, there are 4 of them now. The CD20s like Ocrevus and Rituxan, there's going to be, and Kesimpta, and then there's a 4th one coming, and Lemtrada. These medicines, you have to wait till they wear off enough before it's safe to give a live virus vaccine. But because it's the chickenpox vaccine and you kind of like to be immune to chickenpox if you didn't get it, you can get chickenpox vaccine before you start these things. It only takes a month to get vaccinated. You have to have 2 doses 30 days apart. Where do you get chickenpox from? Well, you don't hear about epidemics of chickenpox because everybody's immune, but you get it from somebody who has shingles. Used to be granny had shingles, granny gave it to the kids, all the neighbors brought their kids over so they'd get it, because everybody knew that chickenpox was a lot milder if you got it when you were 5 or 6 than if you got it when you're an adult, when it can be fatal. The benefit of vaccines so far outweighs the risk. It's just in Vegas, they think there was something wrong with you if you didn't get them, because it's the odds are so much in favor of you being protected by them rather than hurt by them. It's a very small issue. Can we go to the next slide? All right. So who's the new kid on the block? It's COVID-19, whose technical name is SARS-CoV-2. SARS is for serious acute respiratory syndrome, and it's also called COVID-19 Wuhan. And that is not any kind of discriminatory name. That is how epidemics are named. It's related to several coronaviruses. They'll call coronaviruses because when you look at them in an electron microscope, they don't look like this pretty color picture. They look like a shadow, and they have this little haze around them. And corona is the Latin word for crown. It looks like it has a crown on it. And it was previously seen in a couple viruses in Asia 20 years ago. And they managed to quash those by quarantine and careful medical care. But this one got out of hand by the time we get there. And I'm a very firm opinion that the viral sequence is partially artificial and it supports a laboratory origin. I think everybody who's looked at the viral sequence agrees that that isn't from any existing virus. And it's not closely related. There is a little crossover immunity. About 20% of people actually have antibodies that react with the virus. What's unique about this virus that makes it so difficult is it's got machinery to block the cell-making interferon, which keeps it from signaling the neighboring cells about the presence of infection and allowing them to protect themselves. Interferon is a very, very ancient signaling system. Without it, you will die of a virus. And it is one of the reasons that this virus has such a high mortality. The death rate is an astonishing 15% in people over age 60. Not since the 1915 influenza epidemic has there been anything close to this deadly. And many of the survivors have permanent respiratory impairments. They are pulmonary cripples. Let's go to the next slide. All right, so unlike epidemic influenza, it is a very low risk to children, and it's 1 in a million deaths in children who have the disease. And that is unlike influenza, which is much more dangerous in children. And nobody ever thought about the influenza deaths, but 50,000 people die a year of influenza in the United States. And nobody ever took it really seriously until COVID came along and killed 10 times that many in a year. As far as COVID, it's very clear that obesity, cancer, autoimmunity, age, diabetes, pretty much any chronic health condition is probably a risk factor. MS patients don't have a remarkably high mortality, but it depends on these risk factors mostly. Most of the studies evince 2 to 5% will die from infection if they're unimmunized. It is respiratorily transmitted for practical purposes. These are microscopic, invisible particles in the air that are suspended and stay there for some while. They're at the highest concentrations where there are sick people, and in hospital break rooms, cafeterias, outside hospital doors. So you may think that they're being mean to you, not letting you go into the hospital, but honestly, it's protecting you. Ventilation is an extremely effective strategy, and the virus is also very vulnerable to sunshine and UV light. Let's go to the next slide. All right, so how do you treat it? Well, there are many vaccines worldwide. There are 3 approved in the United States. Natural infection produces probably long-lasting permanent immunity in most people, but rarely a repeat infection can occur. They're usually in people who have poor immunity. On average, the vaccines reduce in the near term over 90% of infections, but natural infections, which are usually mild, can occur after vaccination. The B-cell immune responses that they see after 2 doses of vaccine go down about 5% a month, which isn't very fast, and they're still immune. We can't measure the T-cell immunity except in laboratory settings, and they know that there's very good T-cell immunity. And people who've had natural infections have very good immunity. It's probably better than the vaccines by far. And that's true often of other things like chickenpox. That's why the chickenpox test is so reliable and where people have had it, and it's not in people who've been immunized. An additional dose has now been authorized if you had the 2-dose vaccine and for people who are high risk or immunosuppressed. And MS is specifically listed as one of the conditions, or immune suppressing medicines are also listed. You've heard these names, Pfizer BioNTech and Moderna. They're mRNA. They are naked RNA instruction molecules that make the cell produce this little thing called the spike protein, which is the little red triangles you see out there. This is how the virus grabs onto the cell and tricks the cell into taking it inside like a Trojan horse. And what you do is essentially gum up all those sites with antibodies, so it just can't connect to the cell, and it doesn't kill the virus in the sense that the virus it's still intact under there. It just can't do anything. So when they test people, often they still have virus, but the virus is not infectious. The other thing is the T cells learn how to find cells that are making that protein, which are virally infected cells, and they kill those cells. Very rarely there have been complications of blood clots and heart inflammation, but it's thousands of times less risk than getting COVID. So the odds are still in those people's favor. There is no such thing as a perfectly safe drug, but these are about as safe as they get. There is another kind of vaccine which is available at J&J vaccine. It's just basically a virus that's they take one cold virus and they put a piece of the COVID virus in it, so the cells will make that. It'll infect the cells just like the cold virus does. All right, so how do you treat it? There's other things besides vaccine. So you already have it. I got a call on the way here today. Patient, I think I'm coming down with COVID. I got the vaccine 2 weeks ago. They're not immune. What are they going to do? Well, they've looked at a lot of things. And honestly, while some of them are quite controversial, they probably have small benefits, but it's unclear if they change the outcome in terms of hospitalizations or death. And so that's why they are not approved and recommended routinely. But there are a number of common drugs that probably help. However, you need drugs that do big things when you're sick with COVID. And so the MS medicines actually may have some benefits. I'm not talk about those in detail. Some of them may be risks and make the disease worse. But in general, it's kind of remarkable how little people with MS have trouble. The ones I've had have been pretty heavily immune suppressed, the people I've had who suffered grievously with these viruses, or they were quite old. Corticosteroids, our friends with MS, which aren't used nearly in high doses, actually seem to be one of the most simple, safe, and beneficial ways to make the virus injury less. probably because it reduces the inflammatory response to the virus. There is an antiviral compound that's given IV called remdesivir that is approved. It's used in hospitals for sick people. There is something that is hot off the press that has been available for 2 weeks called REGEN-COV, which is anti-COVID monoclonal. So all you people who are out there enjoying the benefits of genetic engineering with your MS therapies that are monoclonal antibodies, if you get sick with COVID, or you're not immune, or you come down with it and are having symptoms, they can passively immunize you. You drive up to a pharmacy, they give you 4 shots in different limbs with 2 monoclonal antibodies, and you are now immune. And that immunization will last, that immunity will last 3 months. We call it passive immunization, not active immunization. But it doesn't substitute for vaccination because it will wear off. Those are donor antibodies, essentially. They're not your antibodies. You don't make antibodies because of that. You have to go ahead and get the vaccine again, and should, if you didn't already. Next slide. All right, so I'm going to kind of wind up here and then let Stuart take us forward. This is what's happened with COVID since the epidemic began, all right? And you see 2 lines here. There's a red line that is the cases every 7 days, which in daily cases, in basically the tens of thousands. And then you see in the yellow line, you see the deaths. And the deaths that occur, it's the 7 deaths in 7 days per 100,000 people. And what you see is when it first came out, there was an extraordinary number of deaths. And when it also peaked, there was an extraordinary number of deaths. But every time we've got a peak, what you see is the deaths come after. They come about a month after, because people try to fight it and they just can't get past the lung injury, and or they have some other complication of being sick. And so the deaths peak always after the infections do. And then what you see is that the deaths are getting less. It's changed in proportions of deaths to cases, because the early cases, it got into the nursing homes, got the spread to the older people, and it was just devastating. And as they get better at treating people over time and learning how to do it, we've gotten some amazing tools. I mean, medicine's moved more rapidly than ever before. And now when you see the most recent peak, the deaths are much lower than we expect. We're hoping that we're at the peak of the current outbreak. This is a more rapidly spreading virus. The Delta variant, just like always with viruses that are endemic, they evolve to be more infectious and less severe. It's still plenty severe. And the good news is that the vaccine is fairly effective. I mean, I've had patients who got vaccinated and still have gotten COVID. It's generally pretty mild. And we have now the tools to treat the COVID. So we're in a better situation, but by far and away, vaccination is the most efficient and safe way to protect people. All right. So I'm going to stop there and let Stuart kind of introduce our questions and what we're going to do.
Yes. Introduce. Thank you. Yes. First off, thank you very much, Dr. Hunter. That was a excellent description of so much that I didn't even know that we had all these things still out there. But yes, I do want to thank you for describing all this. I mean, a lot of people were applauding what you were talking about, and so we're going to have a lot of questions to go along with it. Quite honestly, there are lots of people on Ocrevus that are watching this tonight, and that dominates the questions. You might have spoken about some of this. I got MS. I can't remember everything. All right, so that's a good excuse for this time of night, right? But we're going to go over a lot of questions, and there are people that have been asking things online as well. What I do want to tell everybody first is that everything that you saw tonight, and people are asking if they could get copies of the slides, the answer is yes. You can get the slides, but only in video format, all right? And This video will hopefully be made public in about a week because I'm just far behind in getting our programs published. All right, so it'll be about a week, and this program will go up onto our YouTube channel, and everybody that's on here tonight will get an e-blast saying how you can watch this. All right, and then you can watch the whole presentation again, and you could, go through all the slides. All right, so that being done, I could get rid of several people that were asking that question. All right, next. Let's begin anywhere, right? And we're going to jump around. Some of it is going to be the MS medication. Some of it's just going to be about the disease and whatnot, and we'll go from there. So one of the questions that keeps coming in, though, is that people want to know how they could check their antibodies from being vaccinated. Okay.
That's a very good question. Let me tell you, here's the problem. No test is perfect. The COVID tests are about 85, 90% accurate. That means you can have COVID and the test is negative. That means you can not have COVID and the test is positive. It's not great. The antibody tests are even worse than the COVID test. Okay, the antibody, and the problem is this: is the antibodies can be absent and you're still immune. If you had the vaccine, it's very possible to be negative and still be immune. Why? Because your T cells know how to fight the virus. All right. And the other thing is it's been long enough, the antibodies may have gone away, but they'll come back as soon as you get vaccinated. Because you have what are called memory cells, which are just hanging out waiting for something to happen. They've seen it before and they know how to start up real fast and make millions of copies. So you can get tested for spike protein to see if you've got a response. The easier thing, if you haven't had the third dose of vaccine, just go get the third dose of vaccine. Almost everybody has very gratifying or off-the-chart responses. I a lot of times get the question, I present this about the Epstein-Barr, do I need to get tested for Epstein-Barr? And my answer is, don't bother. People with MS are always off the charts positive. This is what we know. It's just how it is. And I've never had anybody who was negative, ever, in 30 years. So don't bother. As far as testing your antibodies, if you've been vaccinated, you should assume you're immune, even if you're on MS medicines. And people on Ocrevus and Rituxan and Kesimpta, which are anti-CD20s, it's very often they don't have antibodies. And it doesn't really matter. You're still partially immune, and you should get 3 doses of vaccine. With Ocrevus, I usually recommend, unless people haven't had it at all, to wait about 3 months after their last Ocrevus, because then there's not going to be as much suppression of the antibody response. Vaccines have been studied with Ocrevus and related medicines. The problem is this: if you've seen it before, the response is decreased but okay. If you haven't seen it before, the B cell response is 0. That doesn't mean you don't have a T cell response. You just don't have much of a B cell response. So it's a challenge. If you end up off Ocrevus for a few months of longer than usual, go get a booster. Go get a booster. But for example, if somebody gets, if somebody gets a vaccine for pneumonia while they're on Ocrevus, they get a response. It's just not as good a response. Because they've seen it before. They have these memory cells. But if you don't have those memory cells, your response is weaker. T cells are pretty good at dealing with this virus. But now we have this drug, REGEN-COV. It's named after Regeneron, the company that made it, who engineered the antibodies and showed they work. It basically just sticks to the spike protein. It does what your immune system tries to do. Over many weeks and doses, it does it in 2 hours. Okay, because it gives you from somebody else, it's from a lab culture. This immunity temporarily helps you fight this virus at early stages, which makes all the difference in the world. They can't give it to people who are already extremely sick. It'll kill them. It'll make them sicker. But if you're still walking around, it changes. It's 70% less hospitalization. It's amazing. The other medicines we're just not as sure about. Some of them are probably protected. Interferon beta was tested in people with COVID. It probably helps. Glutarin acetate probably makes it milder. Aubagio probably makes it milder. the S1P agents, there's stuff on both sides. It's not a big risk. It's not a big risk. I don't usually have people stop their medicines. As far as the vaccines, most of these, other than Ocrevus, most of the drugs don't interfere with the vaccine.
My turn.
Okay.
All right. We got a lot of questions. All right. And I've got to get through these. So I'm going to ask you to tighten up some of your answers. All right. And let's just go through the questions because each one of your answers are producing another 6 questions. All right. And you've only asked one answer. You've only answered one so far.
It's the immune system. That's how it works.
That's right. All right. So let me ask the next question. All right. First one, Yolando is asking, when do you get the booster with Kesimpta?
Well, I tell people who are on Kesimpta because the way it's dosed, because Kesimpta is a small dose of anti-CD20 every month, except the first month when you get loaded up. So I tell people to skip one dose 3 weeks after they would have gotten it to go get their booster and delay, save their, and this is my way of doing it, okay? To save that dose and the next dose till 2 weeks after you would, when you miss the second dose, and you're a month after, 3 to 4 weeks after your vaccine, and then you again do the weekly dose and catch up, like you did just to start it. You do week 1, 2, 3, and you catch up. So basically, you don't interfere. You don't come in there with a Kesimpta and obliterate your B cell response to the vaccine when it's there. And Kesimpta is different than Ocrevus in that it doesn't completely eradicate B cells. So you just want to let the B cells grow before you knock them down again, because that's how it works. That it doesn't do anything to the T cells. You'll still have T cell immunity, but if you want a good B cell response, that should work. I'm just making it up because there is no experiment that's shown this. That's how it should work.
Okay, thank you. Next, Judy is asking, if you test positive for COVID, how do you know if you need a treatment or if you should go to the hospital? And what if you've been vaccinated and this happens to you as well?
Okay. Well, usually there's a reason you tested, and the reason people tested sort of determines what you're going to do. If you've just been exposed and you've been vaccinated, you can presume that you're immune, or at least some degree of immunity. It doesn't mean you won't get sick. And the problem is it depends on how sick you are. If you've got a bad cough and fever and headache and you're in a bed, please go get help right away. I've had some MS patients get horribly, horribly ill like this who weren't vaccinated and very quickly. And there are medicines that you will not be able to get if you don't get there quick, like that Ridgeon-Covey. They're not going to give it to you if you're on oxygen in the hospital because they're being afraid of making it worse. They have to give you remdesivir. May not help. So what do? If you're just positive and you feel fine, don't worry about it. Wait and see what happens. Isolate. Don't give it to somebody else. You don't need to get the vaccine again right away. I'd wait till it's clear you're not going to come down with it.
Okay, thank you. All right, next one. Let's talk about travel. All right, there are a lot of questions from people that want to know about air travel, sea travel, land travel, all right? Travel to different portions of the United States where they can find out where there are spikes going on. Spikes. What do you call a spike these days? Is it for the unvaxxed or is it for those that are vaxxed? How do you tell what's good for who, where?
Let me tell you, if you're in close quarters with somebody who's infected, you're going to get it. It's just that infectious. It's as infectious as chickenpox or measles. You walk through an airport and somebody has measles, you're going to get it. And this virus is just as infectious. Masks, if you got to be things. If I was going to be out if I had to be out in the public and I knew I wasn't immune or I'm very sick and vulnerable or older, I would wear an N95 mask. I would consider a face shield. They don't help as much, but adding up together does. And ventilation makes all the difference in the world, not being in a small space with other people. Airplanes actually have pretty good ventilation. But that said, if there's a bunch of people who are sick on the plane, you're going to get it. So think real hard where you're going if you want to be there when you get sick, if you're going to be there a couple weeks, because you need to be that. But we've never had so many ways to treat it if people get sick, but we'd rather you didn't get your immunity naturally at this point. But you will have good immunity if you have COVID. It's a very, the thing we worry about is people surviving. People who've been vaccinated, the odds of dying from it are very small. It's like 1 in 1,000 if you get it again. But it still is a very bad illness for many people. Most people, it's like the sniffles.
So let's go forward now. Let's talk about, for those that get the booster. First off, this is the first booster. How many times are we going to have to get boosters? That's the first question. The second question is, can a person that's gotten the booster feel more comfortable by being on that jet?
I would get the booster. It would depend on that person, how old they are, what their other diseases are, what medicine they're on. I mean, if somebody's gotten cancer chemotherapy or a stem cell transplant or has been on Ocrevus a long time, I'm not real confident of someone's immunity, okay? But on the other hand, it could be no problem. There are people all the time on Ocrevus who've gotten COVID, and it's no big deal. I didn't have anybody die, any of my MS patients on Ocrevus pass away, even unimmunized, all right? I've had some who had NMO. I've had 3 patients with NMO die. They're on steroids and azathioprine and Rituxan, which is a very more aggressive treatment, and they all died very fast. So as long as you've got an immune system, it's going to work. But if we've short-circuited it, try to keep you alive, it may not protect you.
All right, not everybody on this conference tonight know what NMO is. I mean, I do, you do, but I'm sure we got a lot of people online right now. So you're going to have to explain real quick what NMO is.
We used to call NMO really bad MS, but it's actually a different kind of inflammation from MS. The last 20 years, we've understood it separately from MS, but it acts like MS, but it's a very, very wicked immune disease, and we have to use a lot more aggressive immune suppression with it.
Okay, so going back to the booster, there are a lot of people that obviously got the vaccine and they were scared to get the vaccine. Now they're even more terrified that what's in the booster and what is it going to do to them. Can you explain if there's, what the difference is between a booster or just getting the vaccine a third time? Is there any difference?
It is exactly the same vaccine. You get it again. And there is not a small chance you get some kind of vaccine reaction. The usual thing is a feverish feeling and some malaise and a sore arm. People with MS sometimes get more dramatic responses. I recommend everybody take an aspirin-like pain reliever. My favorite one is naproxen. Take 3 of them before you get it and another 2 before you go to bed, and take 2 in the morning because it can hit you 24 hours in. And if you get a fever with MS, with bad MS, you're going to have trouble doing things until it resolves. But you get your fever down. You can always take, if you get a fever on top of the naproxen, you can always take Tylenol as well, and to help get that fever down. And it is not, it is usually as soon as the fever goes away, so will the MS symptoms that come along with the fever.
Okay, thank you. Mary Lou is asking, are people with MS immunocompromised or not?
Well, it depends on whether you're going to use a big I or a little I and what medicines they're on. So people with MS don't die from viruses normally. They really don't. It's not the problem they have. They mount really effective viral. Their whole immune system is like a viral illness. It's going full bore all the time. Some of the drugs like interferon beta and glutarium acetate, they're gunning parts of the immune system. So they really are not immunocompromised in the traditional sense. However, older patients with MS have kind of burnout immune systems. When you get in your 50s and your immune system has been gunning for the last 4 decades because of MS, it doesn't work as well. That's why patients with MS die. They die of bad immunity. And, it's not that much worse than everybody else, but it is worse. And that's why vaccines are so important. I spend a lot of my time trying to make sure people get their vaccines, because people, once they grow up, they think they don't need vaccines anymore. And really, your life is a lot better with vaccines. And anybody who's ever had shingles can tell you that.
Are you trying to tell me I should stop doing air travel? I'm in my 60s.
No, it's just you should make sure you have a really good mask. And my solution to avoiding TB when I was practicing in a hospital where everybody had multi-drug resistant TB was I would not inhale. You can't do that for very long.
That's right. That's right.
2 minutes is about the limit.
What if you bring your own oxygen tank,
Well, if you have a spacesuit, you're all set.
That's right.
You will not get infected in a spacesuit. That's for sure. Okay.
Next, we have Kay is asking, do low CD4 and CD8 increase infection rates? Had I can't pronounce it, Syngonomus, Sphingomomas. 3 times.
I'm not sure what that is.
Syngonomus possimobilis. I feel like an idiot. I can't say
it. Sounds like it's an opportunistic infection that they've had because they have a weak immune system. You're really high risk if you get things like that, rare infections. People who are on S1P modulators like Gilenya, they get uncommon things. In our area where I live in the Nashville, the Tennessee Valley and Ohio Valley, people get there's a fungus in the air called histoplasma, and people on steroids get that. Steroids are very effective at shutting down your immune system. Steroids are probably the biggest immune suppressant of the bunch. People are just familiar with them and don't worry about them as much as the other drugs.
So the rest of Kay's question was, does long-term use of antibiotics affect the MS immune system?
Yes and no. It doesn't hurt your immunity as much as it gives you bacteria that are very resistant and serious bacteria which are very resistant. That's the problem with using a lot of antibiotics, and people get bad bladder infections, bad chest infections, bad sinus infections, and bad bowel infections who are on a lot of antibiotics, because it destroys the protective bacteria and it teaches the bad ones how to not respond to antibiotics.
Okay, thank you for that. Now, Michelle is asking, I have PPMS and not on any DMDs. I rarely get sick, don't think I've had a cold in 5 or 6 years, and have never had the flu. I've had my 2 COVID vaccines, not mRNA. I had 0 reaction to either. Why would that be? How would I know if my body was actually, has made antibodies?
Your immune system isn't like the other people, and you ought to get the 3rd dose. The fact that you didn't get some kind of noticeable feeling on the 2nd dose means your body doesn't produce quite a normal response. What your immunity's like, we don't know, but you're better off getting more challenges to it. And
okay. Thank you for that. All right, next we have Sherry. I may not pronounce it right. Sorry about that. All right, isn't it kind of pointless to get vaccines if you're on Ocrevus? Since it kills B cells, doesn't it make it useless to get a vaccine?
As I was talking about, we can't measure the T cell immunity routinely in practice, but we know it's there. It's been done in research. The T cell immunity is actually quite strong in vaccinated people and in people who've had COVID. It's just as important as the B cells. If they forget about it, people focus on the antibodies because they're easy to measure, relatively speaking. And so vaccines are really important to train your T cells. Most people out there don't get chickenpox because of T cells, not because of B cells. The antibodies actually don't protect you very much from chickenpox. It's the T cells that protect you. If you go out there and you check an antibody test, almost everybody who did not have Natural chickenpox is negative, but they're still immune. What matters is that you got the vaccine.
Okay, thank you. Next, Stacy's asking, this has nothing to do with MS, I don't think. Yellow fever vaccine. If a young if a young MS patient is not on an immunosuppressive DMT, don't worry, I'm on one, she writes. Are they still not supposed to get a yellow fever vaccine? And if so, why?
Absolutely, unequivocally, without any reservation, I can see the yellow fever vaccine is incredibly dangerous for MS patients. They should not take it. I have seen it cause MS, okay? It causes a disease like MS in many people. Do not take it. Do not take it. People die from the vaccine sometimes. It is not a safe vaccine for anybody but young people who are healthy. You know, they should not, anybody else shouldn't take it. If there is yellow fever in the area, do not go, especially if you're a Caucasian. If you get yellow fever, you will die. Almost everybody dies who gets yellow fever. So.
All right. Christy just wrote, you just said, you, Dr. Hunter, just said you're exposed. If you're exposed, you'll get COVID. My son had COVID and I did not get it. Some of us are just naturally immune. I'm not,
exactly.
and I'm not vaccinated, she wrote. Since I'm not on a DMD, am I still immune compromised?
Well, compromise, there are different degrees of compromise. There's bubble boy, which is at one extreme where anything they get, they're going to die. And there are people who are just a little bit, you know, they're naive, essentially. The immune system, the problem is with the bad virus is by the time your immune system gets geared up to fight it, you're dead. You know, that's what happens with the flu and Ebola and things like that. Before you can even mount an immune response, you're dead. So immune compromise is relative. And if you're walking around out there and healthy, you're not that immune compromised. But we don't know. You don't know who's going to be the one who dies. We can't tell who that's going to be. It's a roll of the dice. It's 1 in 6 when you're over 60. I mean, if you're older, the risk is incredible. I've never seen so many relatively at-risk people be so laissez-faire about a completely deadly illness like COVID as I've seen the last year. The vaccine is very safe. You know, I can't tell you how many people, how many patients, probably 10 this year, unvaccinated patients who've died in my practice who were fairly young and not real high risk because they didn't go get the vaccine. And you know, just get the vaccine. It's real simple. It really, even if you still get COVID, it's usually really simple and it's not a big deal. If you're lucky enough to be naturally immune, and this person may be, I may be in the same situation. I don't know, because I had a dozen people get COVID sitting right next to me, and I didn't get it because I think I had it already and I gave it to everybody else. But I think I had something like it before this epidemic. But you know, I'm still. If you get it and you get it bad, your life will change if you're still alive.
Good, thank you. All right, Stacy, the one with the yellow fever, wrote not that she had yellow fever, but she wrote, "Wow, I got the yellow fever vaccine because I traveled all over the world, and that was before I got MS." So she's just commenting after what you had said, and she again writes, "So I probably already had MS when I got the yellow fever vaccine because I'm PPMS if I didn't get sick from the vaccine at the time, but now I wonder." So she's wondering if she could have gotten
we're
MS.
gonna all have to wonder because we can't know, but no, you would have gotten sick right away if you got sick from the vaccine. It causes a horrible MS-like illness in some people.
All right. So next, before I get into all the questions again that came in when people registered, I just Denise is saying, as an Ocrevus patient, she wants to thank you for addressing all of us getting the vaccine booster and so on, everything to do with the, you know, as far as, I guess she feels you answered everything about Ocrevus. But we still have Ocrevus questions coming, so stay tuned. Here we go. All right.
What my mentor always told me, if I don't know the answer, make up a good one really quick.
Sure, it sounds great. All right. Next, person writes, learning how to stay healthy and safe with MS. I am 75 years old, or I've had MS for 75 years. I can't tell what she really. Oh, I am 75 years. Have progressive MS. I'm not on any medication that degrades my immune system, but would I still be eligible for a COVID booster earlier than 8 months?
You're eligible for a COVID booster 30 days after your last immunization if you have MS. You can go right away.
Right.
It's already in the books. Just tell them you have MS and you're you have you can call it immunocompromised if they don't understand the MS, but it's listed specifically.
That's right.
As a reason.
That's right. I actually know somebody whose wife, he has MS. His wife does not, but she went into a pharmacy and said, I have MS. They don't question anything. And for anybody listening, they don't question, all right? If you tell them that you have MS, which you all do probably, because that's why you're online tonight, all right? But you can go in and get the booster. All right, next person. What are we learning about the differences in vaccine immune response between ofatumumab and ocrelizumab, or even fingolimod, and I had never heard of this one, but oh, she's probably saying orposinamod.
Ofatumumab. Well, that was an experimental drug that doesn't do anything in the immune system. Let's talk about the big classes of MS medicine. So we talked about glatiramer acetate, which was called Copaxone, and interferon beta. These boost immune responses very powerfully. Okay, and you actually have Copaxone will double your antibody responses. Interferon increases them by about 50%. As far as Aubagio actually is in a class by itself, but it acts like an antiviral drug. It is antiviral in the laboratory, but we don't know if it's good enough antiviral drug to make a difference in COVID. The anti-CD20 drugs are basically different doses of the same kind of treatment. The thing that's different about ofatumumab, or Kesimpta as it's marketed, you see it on TV all the time with catchy actors, pretending MS is a walk in the park. But it is basically a low dose that doesn't completely obliterate the B cells, but works quite well to control MS. It beat the pants off of Aubagio. And what really amazed us is Aubagio knocked down the immune system more than the Kesimpta did when it was studied. It completely was the opposite of what we thought was going to happen. So it's really not a strong immunosuppression, but ideally you don't get the vaccine right at the time you get the dose. You want to wait till you've got B cells to play with, and then you can catch up again, with it. I don't know. It might turn out to be the opposite. But the S1Ps, Gilenya, there's 4 of them now. Mayzent, Zeposia, and Ponvory. They all work basically the same way. They corral immune cells inside the lymph nodes. Technically, vaccines work in the lymph nodes, so it shouldn't be that big a deal. And slowing down immune cells isn't necessarily bad for a viral infection, because they do a lot of damage trying to get to the virus. And once the antibodies get on the scene and slow it down, then it's not a problem. And those drugs don't do anything to antibody responses. Antibody responses are quite good because the lymph nodes are intact. It's just the cells have a hard time getting out.
Okay, thank you. All right, we have a question coming all the way in from the United Kingdom. All right. On the MS Society website, United Kingdom, elsewhere too, I read that COVID vaccination not recommended during relapse, but I don't know why. I am relapsing, but not on meds and not yet vaccinated. I want to get better first. Is there any data or information on this?
Well, if you're going to get steroids, it will knock down the vaccine response. If you're in a relapse, the only reason I can think of they made the recommendation not to get vaccinated had to do with potentially worsening some of your MS symptoms transiently or causing an unknown change that might be permanent. It's caution. It's not I mean, if you're really high risk, I mean, people with MS, I mean, if you're not going to have the problem now, you're going to have it later too. So, you know, MS relapses in general aren't emergencies to treat. If you're not real impaired, I mean, if it's a mild relapse like sensation or minor double vision or something, you know, I don't see a reason not to get the vaccine to get the show on the road. It might even distract the immune system. That's how Copaxone works.
Okay, next. Is an MS patient's boosted immune system more effective in protecting against infections than the immune system of a person without MS who does not have a boosted immune system?
Yes and no. It depends on which test you do. If you look at their response to Epstein-Barr, it's off the charts. Okay, but if you look at their response to other new things, it's not so great. You know, so it's probably not normal, but they're not. Most of them, on average, they're not that different from normals. So, but there are exceptions. We recognize this because we know that some MS patients have really crappy looking immune systems at young age, but it's not the average patient. It's a slice of them.
Okay, thank you. Next, is the vaccine recommended if a person with MS is not on a DM? Any concerns since the blood-brain barrier is open?
No, there's no concerns. Lots of people have got vaccinated with lots of things. And what the immune system does when it's responding to a vaccine is very much like what it does with Copaxone. Copaxone might as well be a vaccine, the way it works.
Okay, next, Carolyn's asking, other than the recommended vaccines, what is the best way to keep your immune system healthy as you age?
That's a great question. So, you know, the number one thing is not to smoke. Smoking burns out your immune system. It turns on that Th17 and guns it like you're racing an engine. It's terrible. And so does MS. So control your MS. Don't smoke. Don't breathe somebody else's smoke. If you're in a big city with pollution, get out of the city and take care of your immunity. If your cholesterol causes your immune system to burn up, to go nuts. If you have a metabolic syndrome or high cholesterol, get on statins. It really greatly makes the MS better. As far as other things, fish oil. If you don't eat fish several times a week, tuna, salmon, herring, cod, those oily fishes, that's naturally anti-inflammatory. Coffee and tea and fruit, not just sugar in fruit, but like berries, strawberries, bananas, pears, apples. These are loaded with antioxidants, loaded with them. They protect your body and your immune system and your brain from the damage. Right. Omega-3 protects your brain from injury. It's very important. Speaking about omega-3,
it's not asked, but it has been in the past. What is a good dosage to take of the omega-3 fatty acids?
Well, that's a good question. So, you know, it's a mixture of two main fatty acids called EPA and DHA, and EPA is probably the more important one for immune function and cholesterol. DHA is important in children. You really have a hard time separating them. They make pure EPA for vascular disease. It's very expensive, but it can be gotten. It's fine if you got that. But there's also data recently that suggests too much DHA is bad for you. Okay, you have to have DHA. I mean, children's brains don't develop without it. But too much when you're older. So if you take too much fish oil or too much omega-3s, you can get omega-3 from other things besides fish. You can get it from krill. You can get it from there's several vegetable sources, nuts especially. If you get too much, it looks like it could damage the heart. So moderation.
Right.
You know.
What about vitamin D?
Yeah, vitamin D, as you need a level over 50 in the winter, and the people with that have MS. It's half as bad as everybody else.
Okay. All right. Next, are COVID breakthrough illnesses more prevalent in MS patients on DMTs?
I will venture to guess yes, but we don't know.
Right. What about the COVI-MS registry? Or do you send people to look at that?
Well, I haven't seen enough organized data out of it, but what reassures me is it doesn't look like it's a really big risk. There might be a slight risk from some of our stronger medicines, but on the whole, MS patients don't die of viral diseases. There's a couple percent that have gotten bad COVID and died. And there's about 10 to 15% end up in a hospital. And I've had very, very sick MS patients survive COVID, no problem. So I don't think you can predict. I
Okay.
think you get vaccinated and you take common sense precautions to keep from getting it. The risk is far lower of serious illness after you're vaccinated.
Right. Good to hear that. Good to hear that. By the way, for anybody that doesn't know the COVI-MS registry, you can go to the MS Views and News website, and on the lower right of the website, there's a button for COVI-MS. Click on it and go take a look at what's there. Okay. We have a few questions remaining about this topic tonight, so I just want to fly through these, and then everybody could go to bed on the East Coast because it's getting late. All right. First one is, I'm afraid of getting shingles and shots. Although I've had no effects or felt the COVID vaccinations, what do you think?
So it's somebody who doesn't want to get the shingles vaccine. The shingles
Or any
vaccine.
shots?
Or the COVID vaccine.
Yeah,
Go in there, look the other direction, and bite your tongue or something, and it'll be over before you know it. It doesn't
Actually,
hurt to get the vaccine. It really doesn't. Your arm gets a little sore afterwards. It's
right.
painless. The mRNA vaccines, you can't even feel it when it goes in.
That's right. That's right. All right. Next one is, I've heard my immune system is not compromised on Tysabri, just altered. In what way is altered? In what way is it altered, and how does it affect me being susceptible to infections and other stuff?
So the best way I could say what your immune system is doing when you're getting Tysabri is go up to a beehive and kick it. It's going full blast, 90 miles an hour. It's probably great for a vaccine response because the Tysabri is like it's like a steel building that keeps the hurricane outside. All the storm is outside. It ain't coming inside. And it's going like crazy out there. So your immune system is very hopped up on Tysabri. People on Tysabri only get serious immune infections inside the brain because that's the only place that the immune system can't get to at the time.
I explain, people ask me, what does Tysabri do to the brain? I said, well, you know how you have that ice cream cone with the chocolate shell on the outside, and it's hard to bite through. I said, well, that's like what happens to the brain with Tysabri. Is that not correct?
Well, yeah, the Tysabri actually gets into the brain too, and what exactly it does in there, we're not sure, but it probably isn't bad because people feel great on it. The problem is when people come off Tysabri, that's the immune system's still going 90 miles an hour, and those cells are all waiting to get in. That's so you have to switch in a very orderly fashion. You don't want the Tysabri to wear off before you start another MS medicine.
Right. So essentially, though, a person that's on Tysabri should feel great about getting a vaccine. Is that what you're saying?
Yeah, they should. They should feel invincible.
Okay, great. All right.
The only virus you got to worry about when you're on Tysabri is PML. It's BC virus, and everybody's got that one too. Whether they think they did or not, they've got it. It's just they don't have antibodies to it. They've got T cells to it. That's what our tax dollars have shown, is that basically everybody has that virus. It's just a question of how much you respond to it.
That being said, then a person on Tysabri, you're saying, is unlikely that they'll get shingles?
No, it can happen, and it can be more severe because it can get into the brain. Okay. But the risk is probably about the same as everybody else. So 1% of MS patients a year on stronger immune medicines get shingles. On interferon, it's a half of 1%. probably because the interferon really slows it down. If you get Limtrada in the first 6 months after you get Limtrada, it's 10% because it really slows that immune system down, especially the first 6 or 8 weeks. But we know that vaccine responses are normal practically in Limtrada by 2 months. So we just have people hold off on Limtrada for a couple months, a little longer with Ocrevus because there's a really long interval, and we try to time the vaccines so that people get the most, because the insurance companies won't. If we screw up and waste a torpedo, one of the shingles shots on when your immune system doesn't respond, they won't let us do it again, or you have to pay $350 for it to get it.
Okay. All right. Here comes a question that we have not had anybody, I don't think, ever ask. How careful do we as MS patients have to be with going to a grocery store, running small errands, or going to physical therapy? And this person writes, I wear a mask and have been vaccinated, but where do I have to still draw the line?
Well, don't kiss anybody that you think is sick. You can't completely prevent infections, but if you're younger and you're vaccinated, and you have MS, you're probably okay for the most part. Can you get COVID? People are getting COVID. I mean, but it's mild COVID, when they're vaccinated. If you're a month after your first vaccine, the odds are pretty small that you're going to get it's really small. Less than 1% you're going to have a serious life-threatening COVID infection.
Okay, thank you. So another question, how safe is somebody to go to Tennessee to do an MS event in the early part of October?
Nobody's dying in the streets, but the hospitals are full of people with COVID. And,
well, are they unvaxxed primarily, or why?
Yes. About 10 to 1 unvaccinated people.
Okay. All right,
so
great.
In my county, which is the most vaccinated county, the vaccination rate is 60% in the whole population of over 12. Okay. And in the over 70, it's 90%. So it's not badly vaccinated. It's just, the problem with this vaccine is you're not going to stop this till everybody's immune, because it's so infectious. And the most analogous thing I can think of is measles and smallpox, where
Sure.
You had to get virtually everybody vaccinated to stop it from continuing to propagate between people who didn't have enough immunity.
Right. All right. Last question. It's really not COVID related, but I'm going to ask it anyway. 3 weeks ago, my absolute lymphocytes hit 304 within days of my second cycle of Mavenclad. What precautions would you recommend to keep my infection risk low?
Well, the good news is by 5 days after you finish that last Mavenclad pill, your immune system can respond to anything, okay? There is nothing in its way. The reason the lymphocytes are lower and they may go lower still is because those really activated lymphocytes that are causing your MS get poisoned by the Mavenclad. And it may take them weeks to disappear, but they will disappear. And your lymphocyte count will go down. But what's still there in the tissues is perfectly capable of responding. These are just cells that are circulating. Why are they going away? Because they were bad cells. They've been assassinated by the Mavenclad. That is what that drug does. Those cells were very active and they're gone. That's how it works. It's kind of like Harry Potter's magic wand for MS. It really, really is a nifty drug. We're going to find out in the long term how it goes, but it's been studied for 30 years. 30 years I've been seeing people treated with that drug. You can go get a vaccine. You can respond to anything. It's not going to be any different. The time where you don't want to take Mavenclad is when you might be coming down with it, because it will obliterate the immune response if you were coming down with it at the time you took it.
Okay, one more question. Sorry, it's another international question from Canada. Hi, thanks for all the info. 3 questions. I had tetanus and diphtheria and polio in 2018. Do I have to get again? And if yes, when? Do I have to get it again? I guess
So
we're
if
talking
you're
about
an adult,
vaccines.
you only need the DPT once. They usually recommend it at age 50. And the polio vaccine, you only need if you never had it. First of all, the first time children get polio vaccine is like at 3 months, they get the injectable one now. That's what prevents them from getting polio from the vaccine. All the cases of polio for like 30 years in the US were from the vaccine. It's rare. It's very rare. But the oral vaccine still is out there. You've probably gotten the oral vaccine infection strain many times. Every time you had one of your kids immunized, you probably got it again. So you've been immunized repeatedly to polio, and you have good immunity to it. Immunity that's enough to prevent a serious brain infection with the polio. But you can still get polio and get diarrhea from it and not realize it was polio.
Okay, so that person had one more question, but before everybody starts disappearing on me, I want to let you all know that we're doing MS Neuro TV tomorrow night with a program called Healthy Habits. All right, it's healthy things for you to be doing with multiple sclerosis and during COVID. Okay, so that is being presented by Megan Weigel, and we do hope to have you back online tomorrow night. And then next week we have Labor Day, we have the holidays, we have Pilates, we have another MS program happening next Thursday night. I don't remember which one for sure, but it is happening. And by the way, on September 20th, for anybody that's from Georgia, on September 20th, I will be in Atlanta, Georgia, doing a program with Dr. Ben Thrower and Jeffrey Siegel. Yep, he's going back on tour with us as we can get out there. All right, and Dr. Thrower will be speaking about a new thing that they have at the Shepherd Center relating to stem cell therapy. And so I want to let you all know about that as well. That will be on September 20th. Tamina's asking one more question. She's the one that's from Canada. Were you saying that you talked about coffee and tea, and that's her internet cut out for a moment? So she wants you to repeat whatever you were saying about that, please.
Coffee is really, really good for MS. Okay.
Right.
It is a powerful brain protection, and caffeine is good for your immune system too. Soda is really bad for your body. Sugar is like poison. So coffee and tea without sugar, would be my advice. And there is no problem with MS and artificial sweeteners if you need them. But
trust me.
Yeah.
Trust me, I drink 5-6 cups of coffee a day, and I am strong.
The data is it's really good for MS. So it's out of Sweden. People who drink a pot of coffee a day are better than everybody else. And people who drink a lot of coffee and tea don't get Alzheimer's disease at the same age.
Well, that's good to hear. That's good to hear. So I can't keep using the excuse that I'm forgetting everything. All right. There are a lot of people saying thank you for everything. All right. Happy holidays. Thanks to you both. And I'm going to thank Dr. Hunter for everything that he did tonight. I want to thank everybody that's online, because we can't do these programs unless you get online with us. So I greatly appreciate it. Sorry for the glare of my glasses, but you got to be at the studio. These lights are bright. Fortunately, they're not hot anymore. Fortunately, technology made them cool lights, but they're cool hot lights. They're cool strong lights. So yes, there's a zillion people writing thank you again. And Dr. Hunter, I really hope that I can get to Tennessee, because you're telling me only breathe once when I get on the plane. All right. But
only exhale. You're only allowed to exhale.
I will have my K95 and my other mask covering my face, and I will be there. All right.
All right.
So I'm just going to buy out one whole section so nobody sits around me. All right.
All right. All
okay.
Right.
You have a great one. We'll speak soon. And everybody, thank you again.
All right. Bye-bye.
Bye-bye.